Respiratory Module Part 2. The objectives of the Respiratory Module Part 2 include atelectasis, lung collapse, pulmonary hypertension, Goodpasture's syndrome, Pneumonia Syndromes, lung carcinoma, pleural lesions, and nasopharyngeal and laryngeal carcinomas. Atelectasis or lung collapse, which is the loss of the lung volume caused by inadequate expansion of the air spaces. It is reduced in the volume of the lung. It is reduced in the size of the lung. It results in shunting of inadequate oxygenated blood from pulmonary arteries into veins, thus giving rise to the ventilation, perfusion imbalance, and hypoxia. We classified the atelectasis into three forms, according to the cause that lead to this type of atelectasis. We have resorption atelectasis, compression atelectasis, and cicatrization atelectasis. In the first form, resorption atelectasis, which occurs when there is obstruction which prevent air from getting or reaching the distal airways. So, the air already present become absorbed and the alveolar space collapse. Depending on the level of the airway obstruction, complete lobe or one or more segment might be involved. What are the most common causes that lead to the resorption atelectasis? It might be due to the mucus, mucopurulent plaque that might accumulate postoperatively, maybe as complication of a bronchial asthma, in which the mucus becomes thick and viscid, or due to the bronchiectasis when there is permanent dilation of a bronchial tree, or due to the chronic bronchitis, or might be due to the aspiration of the foreign bodies, coin or any foreign body that might be happened due to the swallowing by the children, or might be due to the obstruction lesion as in the bronchogenic carcinoma. The other form of the atelectasis is the compression atelectasis. In other words, it's called passive or relaxation type of atelectasis. It is associated with accumulation of the fluid, blood, or air in the pleural cavity. This mechanically collapses the adjacent lung. The frequent cause of it, congestive heart failure, that lead to the pleural effusion, or might be due to the leakage of the air in the pleural cavity as in the pneumothorax. All of these might lead to the compression atelectasis. Also, the accumulation of the blood, as in the hemothorax, might all of these lead to the compression type of atelectasis. The third type, contraction type of atelectasis or cicatrization, it occurs when there is local or generalized fibrotic changes in the lung or pleura, such as in the pneumoconiosis or in any interstitial lung disease that lead to the fibrotic changes in the lung. Generally, the atelectasis is reversible if it is treated promptly, because we should treat the atelectasis promptly in order to prevent the development of the hypoxia and subsequent or superimposed infection of the collapsed lung. This is a diagram that's showing the types of the atelectasis. Resorption types, as in when there is something blocking the bronchi, or compression type, air, blood, or fluid, which lead to the lung collapse, and cicatrization or contraction type of the atelectasis, which is caused by the fibrotic changes. This is also the collapsed lung. This is reduce the volume or the size of the lung in this patient comparing to the other lung. The other topic that we will discuss today is pulmonary hypertension. Normally, pulmonary blood pressure is 1/8 of the systemic blood pressure. That means 15/10 millimeter mercury. Pulmonary hypertension is considered when the mean pulmonary pressure exceeding 1/4 of the systemic blood pressure, that is say 30/20 millimeter mercury. It's most frequently secondary to the structural abnormalities and the cardiopulmonary condition that increase in the pulmonary blood flow or pressure, or both of them. The chronic obstructive or interstitial lung disease causing hypoxia, as well as causing destruction of the lung parenchyma. So, when there is destruction of the lung parenchyma, as in the emphysema or in the chronic bronchitis or in the interstitial lung disease for any cause, when there is loss of the lung parenchyma or destruction of the lung parenchyma, of course there's the lung parenchyma including the alveolar capillary that become less in number, fewer. So this leads to the increased pulmonary arterial resistance and increased blood pressure. Therefore, the chronic obstructive airway disease, emphysema, chronic bronchitis, leading to the pulmonary. One of the complications of the chronic obstructive airway disease, COPD, is pulmonary hypertension. Interstitial lung disease, one of the complications of them is the pulmonary hypertension. The other causes is congenital or acquired heart disease, such as in cases of the mitral valve stenosis, because when there is mitral valve stenosis, there is increase in the left atrial pressure, which of course lead to the increase in the pulmonary venous return and pressure, and consequently increase in the pulmonary arterial pressure, increase in the pulmonary vascular resistance. The other causes of the pulmonary hypertension is autoimmune disease, as in the systemic sclerosis, that involve the pulmonary vasculatures, lead to the inflammation, intimal thickening and fibrosis, medial hypertrophy, a decrease in the lumen of the blood vessels, which lead to the increase in the vascular resistance, subsequently to the pulmonary hypertension. When all above causes are absent, we call the primary or idiopathic pulmonary hypertension with unknown cause. Idiopathic, we don't know the cause of it. 6% of the cases are familial due to the autosomal dominant mode of inheritance. Regarding the pathogenesis of the primary pulmonary hypertension, is usually due to the mutation in the bone morphogenic protein receptor called BMPR2 signaling pathway. While in the secondary pulmonary hypertension, the endothelial cell function is produced by the process that initiates the disorder. Mechanical injury associated with the left to right shunt. Left to right shunt, that means that from the left side of the heart to the right side of the heart, or due to the biochemical injury produced by the fibrin in the thromboembolism. So according to the cause that lead to the pulmonary hypertension, the endothelial cell dysfunction is produced. Also, decrease in the elaboration of a prostacyclin, of nitric oxide, increase in release of endothelin. All these promote pulmonary vasoconstriction, which subsequently lead to the increased vascular resistance in the pulmonary circulation and lead to the pulmonary hypertension. There are certain plant ingestion of the certain plant, which sometimes used as bashti, also lead to the pulmonary hypertension. Some of the medications, some of the drug as Immunex or olive oil and anti-obesity drug are also contribute as in the pathogenesis of the pulmonary hypertension. Morphology. In both primary and secondary hypertension, it involves the entire arterial tree. In the main elastic artery, atheroma, seen. In medium-sized artery, muscular artery, there we will see there's a proliferation of myointimal cell. Smooth muscle also cause thickening of the intima and media with narrow of the lumen. In small arteries and arteriole, there is thickening, medial hypertrophy, reduplication of internal and external lumina, elastic lumina, and which lead to the complete obliteration of the lumen. According to the clinical presentation of the patient with a primary hypertension, it is different to the presentation of a primary pulmonary hypertension from that of secondary. Secondary hypertension that might be caused by the COPD, chronic obstructive airway disease. Patient has emphysema, mainly patient that have chronic bronchitis or emphysema. Patient mainly is a smoker, commonly is have cough, dyspnea, productive cough, and male smoker, more common in the male and the smoker. While in the primary pulmonary or patient with congenital heart disease has a different presentation, patient with thromboembolism have different presentation. While in a primary pulmonary hypertension, the patient almost always encountered in young persons, more common in the female, presented with the fatigue, presented with the syncope on exercise, sometimes fainting attack on exercise, sometimes that patient has dyspnea on exertion, chest pain, pulmonary insufficiency or respiratory insufficiency, cyanosis. Death might have from right side heart failure or carpomnale, which develop within 3 to 5 years after a diagnosis. The other topic for today is Goodpasture syndrome. Actually, Goodpasture syndrome is a diffuse hemorrhagic interstitial alveolar disease. It is uncommon, characterized by involving both lung and kidney. Kidney, progressive glomerulonephritis, and the lung involved by hemorrhagic interstitial pneumonitis. The main cause, or what are the main cause? It is immunologically mediated, actually, disease. What does that mean? That means the disease caused by the antibody against the basement membrane, against the collagen type 4. These antibodies are seen about 90% of the patient. The antibody against the basement membrane in the glomeruli as well in the alveoli. Microscopically, actually, the patient has necrosis of the alveolar walls with thickening of the septa and hypertrophy of septal lining cells, and there is a presence of the hemosiderin either in the macrophages or extracellularly, which is seen a few days after presentation. Immunoglobulin as IgG or IgM or IgA are seen in the renal biopsy and in the alveolar septa. Treatment of choice in such a patients, actually there's plasmapheresis in order to remove the offending antibodies or immune suppressive therapy in order to inhibit the antibody action. This is a microscopic view of the lung in Goodpasture syndrome. However, the picture is not so much clear, but this picture is showing recent hemorrhage, and this is an old one. We can see here there is a hemorrhage, intra-alveolar hemorrhage, RBCs, loading the alveolar spaces, while here that there is no RBC, just hemosiderin-laden macrophages inside the alveoli and also in the alveolar septa. Pulmonary infections, which include pneumonia. Pulmonary infection in the form of pneumonia is a common disease. It's due to the following reasons. Because the epithelial surface of the lung constantly exposed to many liters of the air which contain various microbial contaminants. Nasopharyngeal flora are regularly aspirated during sleep. Other common lung diseases make the lung parenchyma vulnerable to virulent microorganisms. So pulmonary infection in the form of pneumonia is common. Pneumonia. What is the pneumonia? Pneumonia التهاب رئوي. التهاب في نسيج الرئة. Of course, this is the most important infection actually nowadays, especially it caused by another agent that make this issue is more serious nowadays in all over the world. But this does not consider here because it is bacterial pneumonia. We are considering now the bacterial pneumonia. However, in the future slides, we will discuss the viral pneumonia caused by the coronavirus, which is the most hot topic, actually the serious issue in the community. But we can say that this is what is the pneumonia. Pneumonia mean التهاب رئوي, which is infection of the lung parenchyma, may be present as acute fulminant clinical disease, very severe disease, sometimes fatal disease, especially for the elderly people. Acute bacterial pneumonia, of course, the pneumonia might be caused by many factors, by many causes, viral, bacterial, there's other cause, aspiration pneumonia, especially in the elderly people, and other causes, nosocomial, there are many causes that might lead to the pneumonia. But here in these slides, actually, we are basically deal with the acute bacterial pneumonia. The acute bacterial pneumonia may present as one of two anatomic and radiographic patterns, bronchopneumonia or lobar pneumonia. What is the difference in between? Bronchopneumonia imply patchy distribution of the inflammation. The inflammation appear as patches. The lung tissue in between this patch appear normal. So this type of the pneumonia mainly occurs in the elderly patients and in the very young patients in the elderly patient because of the low immunity, and in the very young patient because of the bronchial tree is shorter than the adult. Bronchopneumonia might be involve one or more than one lobe. This pattern results from infection of bronchi, bronchioles, and it is extended to the adjacent alveoli, air spaces. The lobar pneumonia is different because it includes or confined to the lobe. The contiguous airspace of the part or part of the lobe involved or all the lobe are homogeneously filled with the exudate. It's not like bronchopneumonia in which there's patchy consolidation. There's the bronchopneumonia, part of the lung or part of the lobe, أجزاء من اللوب involved. Tissue in between them are normal, while in the lobar pneumonia homogeneous, all the lobe or part of the lobe is involved, and the alveoli or the airspace filled with the exudate, filled with the inflammatory neutrophils, of course, especially if it's bacterial pneumonia, and fibrin and RBCs and necrotic and dead bacteria and necrotic cells. This is a bronchopneumonia. Look at the patchy consolidation involving one lobe or more than one lobe, while here the homogeneous distribution or involvement of the lobe. This is a lobar pneumonia. This is a bronchopneumonia. Pneumonia syndromes. Pneumonia can be classified into 7 settings according to the infection, according to the implicated pathogens that are specific for each category. It includes community-acquired typical pneumonia, community-acquired atypical pneumonia, which is caused by mycoplasma pneumonia or by viral infection followed by influenza virus, nosocomial hospital-acquired pneumonia, aspiration pneumonia, lung abscess, chronic pneumonia, and pneumonia in the immune-compromised patient. Actually, each of these categories will be discussed in details. Pneumonia syndromes. It is community-acquired typical pneumonia. Most community-acquired pneumonia are bacterial infections. It's not uncommon that this infection might follow viral upper respiratory tract infection. Patient presented with a viral infection might be followed by the bacterial infection. This is not uncommon. It's common. Actually, it's common. Patient has running nose, has mild fever, sore throat, whatever, and the viral infection might be followed by the bacterial infection and pneumonia. This is not uncommon. It might happen. The onset of this type of pneumonia, abrupt or sudden, with high fever, chills, rigor, patient coming with chest pain, pleuritic chest pain, يجينا صدره يوجعه، مسخن كتير، عنده سخونة، حرارة عالية، shaking chills، يرتجف، productive cough, mucopurulent cough, الcough and associated with the hemoptysis, sometimes blood streaks. Streptococcus pneumonia is the most common type of community-acquired typical pneumonia. Common cause of community-acquired, called also pneumococcal pneumonia, it is the same. Other bacteria might be involved within this category is involvement Marxella, Catarrhalix, Staphylococcus, Haemophilus influenza, Legionella, Pneumophilia, Klebsiella, and Pseudomonas species. All of these included within this category. This category is happened or occurs with an increasing frequency in three groups. When the patient have underlying chronic lung disease, as in patient chronic obstructive airway disease, patient diabetic, patient congestive heart failure, asthmatic patient, chronic bronchitis, bronchiectasis, patient with immunoglobulin, congenital or acquired immunoglobulin deficiency, HIV patient, those with decreased absent splenic function. What does that mean? Patient with sickle cell anemia or after splenectomy. This occurs because spleen contain large collection of phagocytes and is therefore which is the major organ responsible of the removal of the pneumococci from the blood. Therefore, those patients with a splenectomy or with sickle cell disease should receive pneumococcal vaccine. Regarding the morphology of this type of the pneumonia, we can see both pattern lobar, the involvement one whole lobe, or bronchopneumonia patchy consolidation that involve one or more than one lobe. The bronchopneumonia more prevalent in advanced age and old age group, and also more common in very young or infants. Regarding the pattern, the lower lobe or the right middle lobe are the most frequently involved. Before the introduction of the antibiotic, the entire lobe is involved by pneumococcal pneumonia, and it evolved into 4 stages. The development of the 4 stages in pneumococcal pneumonia before the introduction of antibiotic include 4 stages. Patient pass into 4 stages of the disease, including the stage of congestion, red hepatization, gray hepatization, and the finally is resolution. But because nowadays we cannot see those stages, because as soon as we diagnose a patient with pneumonia, streptococcal pneumonia, we should introduce antibiotic, and actually strong antibiotic intravenously given to the patient in order to cure the patient and treat this type of the bacterial pneumonia. So we don't see all of these stages nowadays because of the introduction of antibiotic. However, before that, the normal pneumococcal pneumonia passing or evolve into 4 stages. Those are the stages of the. Here we can see the chest X-ray of the patient with pneumonia. The lower lobe consolidation. This is actually the consolidation of the. This is the right side of the lung, and this is the left side, and this is the right side. There is dense homogeneous white appearance due to the inflammation of right lower lobe. This is also the lateral view, and this is the AP view of the chest X-ray. This is homogeneous white appearance of the consolidation. So we will discuss here the stages when the patient with the bacterial pneumonia evolve into. First stage of congestion. In this stage, the affected lobe or the lobes, because there is congestion, become heavy, red, buggy. There is vascular congestion is seen, with of course the proteinaceous fluid outpouring from into the alveoli, with scattered neutrophils, few number of the neutrophil, with a few number of the inflammatory cell. Many bacteria are seen in the alveolar space, actually, this stage of the congestion. The first stage, when of course, and during this stage, the patient feel the heaviness in his lung and pain. Yes, it is pain, because pain or heaviness or because all the lobe, according to the, if it's bronchopneumonia or lobar pneumonia, the lobe is congested, is heavy. يشعر بثقل في صدره البيشنت مع ألم، لأن الرئة في هذه الحالة تكون محتقنة. Engorgement of the blood vessels with blood vessels engorged with blood vessel with engorged and congested محتقنة as a part of the first sign of the inflammation, as you know, and the lung become red, buggy, ثقيلة and heavy. However, histologically we can see only vascular congestion with fluid scattered in neutrophil, not so much in neutrophil, and many bacteria in the alveolar space. The second stage of red hepatization تكون الرئة تشبه الكبد. It occurs within a few days after infection. Lung, red color, liver-like consistency. The alveolar space are packed with bacteria, packed with red blood cells, fibrin, but few neutrophils. This is a microscopic view of the lung in pneumococcal pneumonia stage of congestion. Look at here, in the alveolar wall, in the alveolar septa, there's congestion of the blood vessels with the little amount of the fluid, proteinaceous fluid inside the alveoli, very few neutrophil, and if we get closely to this by high power, we can see the bacteria, showing bacteria. However, here mainly showing that congestion of the blood vessels. It is the stage of congestion. This is a stage of red hepatization. Gross appearance of the lung actually look like a liver because it shows that heavy, dark red liver-like consistency. This is red hepatization, the second stage of the pneumonia. This is also a microscopic view of the lung in pneumonia stage of the red hepatization, in which the alveolar space filled with the red blood cells with the fibrin with a few neutrophils. This is a stage of red hepatization. The alveolar spaces are filled with the RBCs, with the bacteria and fibrin with a few neutrophils. Look at here. This is the high power of the lung tissue. Look at the bacteria. Look at the RBCs and the fluid inside the alveoli. This is the high power of the lung tissue in pneumonia. This is a bacteria. This is the diplococcal pneumonia, streptococcal pneumonia. This is diplococci. This is diplococci pneumonia. Look at diplococci. I think in microbiology you will have it more in more detail, the characteristic of the bacteria. But here, pneumococcal pneumonia that cause this type of the community-acquired bacterial pneumonia is the main cause of this type of the pneumonia, and it's appear as a diplococci. This is a bacteria in high power view of the lung tissue. Third stage of gray hepatization. Actually, this stage, the lung appear dry, gray, firm, with liver-like consistency. The red blood cell lysed, while the fibrino-separative exudate persist within the alveoli. And here, microscopically, we will see that the alveoli are studded and filled with the neutrophil and the scanty bacteria and red blood cell. Of course, scanty bacteria because neutrophil and inflammatory cell engulfing the type of these bacteria, and little RBCs and bacteria with the alveoli filled with the neutrophils in this type of in this stage of pneumonia. The last stage is stage of resolution. This follow uncomplicated cases as the exudate within the alveoli are enzymatically digested by the inflammatory cells, by the macrophages, to produce granular semi-fluid debris, which is resorbed by the time or ingested by the macrophages, or might be coughed by the patient. The pleural reaction in the pneumonia include fibrinous or fibrino-purulent pleuritis, which is the main cause of pleuritic chest pain, because in the patient with the pneumonia patient will have pleuritic or pleural reaction because there's inflammation. The inflammation either in the form of fibrinous inflammation or sometimes fibrino-purulent pleuritis. Of course, it's with the treatment, with the proper antibiotic treatment, may resolve, or if in case not unresolved completely, it's undergo organization, sometimes leading to the fibrous thickening or permanent adhesion. Actually, this is a gross appearance of the lobar pneumonia, which showing homogenous gray consolidation of the lower lobe of the lung. This is a stage of gray hepatization. This is a microscopical view, high power of the lung tissue in case of gray hepatization. In case this is alveoli are filled with the neutrophil. When you see that alveoli, if we given this in the slide in the practical exam, and this you see the alveoli filled with the neutrophil, you have to identify the stage, and we say or we ask you that identify the stage of the pneumonia, and you see that there is a large number of the neutrophil, numerous neutrophil in this alveoli. The alveoli are filled with the neutrophil with the few RBCs and bacteria. You can identify that this is a stage of gray hepatization. You can see this is a congested blood vessels in the alveolar wall or alveolar cell. This is also microscopical view of the lung tissue. In case of the gray hepatization of pneumococcal pneumonia, look at all the alveoli. This is a lobar pneumonia. Actually, it is different from the bronchopneumonia that you see that part or patchy consolidation. Here is the homogeneous involvement of the whole alveoli with the numerous neutrophil and fibrin in the alveoli. In this microscopic view of lung tissue, the feature of the pneumonia, which showing organization of the fibrin into the fibrous tissue, actually with the fibrous tissue deposition on fibrin alveolar spaces. This is occurring in unresolved pneumonia. Unresolved pneumonia, it occurs for any reason. Might be due to the patient doesn't have proper antibiotic, doesn't have proper antibiotic in period of time that should be given to the patient, might be due to the immune compromised patient, immunity, elderly patient, many causes that contribute to the development of the unresolving pneumonia. In the bronchopneumonia pattern, the foci of inflammatory consolidation distributed in patches throughout one or several lobes. These patch or the lesion It's about 3 to 4 centimeter in diameter, elevated, gray, red, yellow. Sometimes confluent involvement of the bronchopneumonia make these foci coalesce to each other and cause lobar consolidation. The lung substance surrounding this consolidation, usually hyperemic edematous, but there are large intervening area are generally normal. That to say, between the patches, the lung tissue appear normal, not like lobar pneumonia in which homogeneous involvement of the whole lobe. There is no intervening lung tissue which is appear normal in between the patches as seen in bronchopneumonia. The pleural involvement is less common in bronchopneumonia than in lobar pneumonia. Histologically, the reaction consists of focal sepurative exudate that fill the bronchi, bronchiole, because here is involvement of the bronchi, bronchiole, and the adjacent alveolar space, appropriate therapy, complete resolution or resolving of the lung is the rule for both lobar and bronchopneumonia of pneumococcal pneumonia. We should give proper antibiotic with the with a period of with a given period of time, like maybe 2 weeks, 3 weeks, according to the response of the patient. So the patient shouldn't stop the treatment, otherwise the pneumonia will not resolve. Therefore, the proper therapy, appropriate antibiotic therapy should be given to the patient, and specifically those patients that sometimes some of the patient need hospitalization, hospital admission, and giving as for the first day of this disease, giving intravenous antibiotic. This is bronchopneumonia, gross appearance of the lung with bronchopneumonia, patchy consolidation. Look at here, this is patch, and in between there is intervening normal lung tissue. This is a bronchopneumonia, and as we say to that, bronchopneumonia occurs more common in the elderly patient and in the young patient, young children or young patient, because of the short of the bronchial. This is a microscopic view of the lung tissue showing bronchopneumonia. So look at here, vascular congestion, glycocytic infiltration in the alveoli with the bronchi. There's inflammatory exudate inside the bronchioles. And look at here, there's normal tissue in between inflamed bronchopneumonia patches. This is also microscopic view of the lung tissue. Look at here, there is a dense sepurative exudate that fill the lumen of the bronchiole. This is another microscopic view of the lung involved in the bronchopneumonia. The complication of severe cases may include, especially in those patients with immune compromised patients have heart disease, have lung disease, chronic obstructive COPD, asthmatic patient have HIV, AIDS patient, immune compromised, immune suppressive therapy, cancer patient which receive or have chemotherapy. All those patients with low immunity, sometimes the treatment not lead to resolving the infection or resolving pneumonia, sometimes might lead to the complication, sometimes in the elderly patient, in very young patient, low immunity, have underlying disease. All of these might come, or this disease very highly or very severe that cannot be combated by the treatment with antibiotic. Anyway, the complication of severe type of the pneumonia include abscess formation, because it results from destruction of the lung tissue and necrosis, empyema, in which there's accumulation of supurative material in the pleural cavity, it's called empyema. Sometimes, as a result of the organization of the intra-alveolar exudate, may convert this area into the solid fibrous tissue. Sometimes there is dissemination of the bacteria into the bloodstream, causing bacteremic dissemination, which might lead to most serious complication that might accompany pneumonia, like meningitis, arthritis, or infective endocarditis, because bacteremia and the bacteria might involve any organ in the body. These complications are more common with the serotype 3 pneumococci. The diagnosis of the patient with the pneumonia. First, the patient coming to the hospital, to the emergency department or to the clinic, complaining of fever, rigor, cough, difficulty in the breathing, sputum sometimes with streaks of the blood, hemoptysis. المريض يجي severely ill patient، تعبان جدا، مسخن، حرارة عالية، rigor، يرتجف، cough، difficulty in breathing، صعوبة بالتنفس، sputum, productive sputum with sometimes streaks of the blood, sometimes there is blood in the sputum، صعوبة بالتنفس. يجي البيشنت تعبان in the hospital. So when you receive the patient, you have to assess the patient clinically first, then send the patient to the chest x-ray, which is very important, to identify the lesion, if the patient has real pneumonia, or sometimes it's just chronic bronchitis, or anyway. So chest x-ray, examination of the sputum of the patient in the lab to identify the microorganism that cause this type of the bacteria, gram staining of the sputum with the culture. During early stages of the illness, blood culture is positive in about 20 to 30% of the cases. Antibiotic sensitivity test must be performed on the culture, on the sputum, in order to identify and determine the type of the antibiotic that should be given to the patient. However, this might take 48 hours, so we have to start the antibiotic that we think it is proper in such an infection, and then we can wait the result of the antibiotic. Either we can change the antibiotic according to the sensitivity test, or it continue the patient on the same treatment. There are certain commercial pneumococcal vaccine that contain capsular polysaccharide that giving to certain type of the patient, especially immune-compromised patient, patient with splenectomy, patient very young, very old patient, which is the common serotype of the bacteria that is available, this type of the pneumococcal vaccine, and it would decrease the risk of the infection for those patients. The other type of the bacteria that cause pneumonia, actually this is one of the most serious bacteria that cause pneumonia because it is a gram-negative. Actually, the gram-negative bacteria microorganism cause a severe pneumonia than gram-positive. Haemophilus influenza is a gram-negative microorganism. Both encapsulated and non-encapsulated are important cause of the community-acquired pneumonia. The former can cause a life-threatening form of pneumonia and meningitis in the children. This is the most common type, the most common type of the pneumonia and meningitis in the children is caused by the Haemophilus influenza, and of course following the viral respiratory tract infection. Also, there are certain of the adults also at risk of this infection, especially those that have cystic fibrosis, chronic bronchitis, CP, chronic obstructive airway disease. Haemophilus influenza pneumonia considered the most common cause of the bacterial exacerbation in COPD. Other type of bacteria, which especially considered the second commonest cause of bacterial exacerbation in COPD in the adult, is Marxella catarrhalis. It's being recognized or considered the common cause of bacteria in the elderly patients. Other type of the bacteria that also cause pneumonia, Staphylococcus aureus. Actually, this is the most important cause of secondary bacterial pneumonia in the children and healthy adults following viral respiratory disease, as in measles in the children patients, especially children in the past when their children didn't receive the vaccine of the measles, so there was epidemics of the measles among the children. So one of the complication of the measles يعني الحصبة. Actually measles is the حصبة. يتحصب الطفل. The most common secondary bacterial pneumonia. Actually, those patients might develop as a complication of the measles, Staphylococcus aureus pneumonia, and also may complicate viral respiratory tract infection following the influenza, both in children and in the adult. It's associated with the high incidence of complications such as lung abscess and empyema. Actually, the Klebsiella pneumonia and Staphylococcus cause the most common cause of the lung abscess. Staphylococcal pneumonia occurring in association with the right-sided staph endocarditis, especially considered as a serious complication of intravenous drug abuse. Those patients that addict IV intravenous drug abuse, that taking the IV drug, they are more liable or prone to get right-sided endocarditis and also Staphylococcus pneumonia. This type of pneumonia caused by the Klebsiella, which is also gram-negative bacterial pneumonia. This usually affects debilitated patient, malnourished patient, immune-compromised patient, chronic alcoholic patient. The sputum is thick and gelatinous, which is a characteristic because of the microorganism which produce abundant viscid capsular polysaccharide that the individual or the patient has difficulty to cough out this type of the pneumonia. This type of the pneumonia predisposes to lung abscess as in Staph aureus pneumonia. This type of the pneumonia caused by Pseudomonas aeruginosa, usually associated with the cystic fibrosis, most commonly seen in the nosocomial setting. What is the meaning of the nosocomial setting? We will discuss this later in this session, because this type of the people that are hospitalized in the hospital, that are staying in the hospital for a long period of time, those people are more prone to have Pseudomonas aeruginosa pulmonary infection or pneumonia. More common in the people who are neutropenic. There is because the neutropenia, or those patients that receive chemotherapy. So in those patients with them that receive chemotherapy, mean that they have neutropenia, decrease the number of the neutrophil in their blood, more prone to have Pseudomonas aeruginosa. And what else? Those victims of burn, those patients that have burn, especially extensive burn all over the body, or those patients that require mechanical ventilation, more prone to have Pseudomonas aeruginosa pneumonia. The characteristic feature of the Pseudomonas aeruginosa have tendency to invade blood vessels at the site of the infection, with consequent intrapulmonary spread. Pseudomonas bacteremia is considered a fulminant disease, severe, that death occurs within a few days. By histological examination or microscopically, it reveals coagulative necrosis because have the tendency to invade the blood vessels. So there is coagulative necrosis of the lung parenchyma with microorganism invading the wall of the blood vessels, causing Pseudomonas vasculitis. So the type of the necrosis that caused by this type of the bacteria that invading the lung parenchyma is coagulative necrosis with Pseudomonas vasculitis because it invading the wall of the blood vessels. Microscopically, the lung tissue in the Pseudomonas pneumonia showing involvement of the blood vessels by the bacteria, involving of the blood vessels, Pseudomonas vasculitis with the focal infarction or coagulative necrosis. However, this picture is not so much clear of the Pseudomonas pneumonia. Legionella pneumophilia. This is the agent of Legionnaire disease. In one time, it became an epidemic, and sometimes it was sporadic form of pneumonia. The other name for this disease is Pontiac fever. Actually, it is a self-limited upper respiratory tract infection caused by the Legionella pneumophilia without pneumonic symptoms. This type of the bacteria flourish in artificial aquatic environments such as water cooling towers and within the tubing system of domestic water supplies. Actually, this type of the epidemics took place within large holes in between the large number of population in air conditioning system because spread by this route. So the tubing system of domestic water supplies and water cooling towers and air conditioning system is a mode of transmission of this type of bacteria. The mode of transmission is thought to be either inhalation of aerosolized organism or might be aspiration of contaminated drinking water. It's common in persons with predisposing conditions such as in cardiac, renal, immunological, or hematologic disease, and also in those patients with organ transplant recipient. This type of the pneumonia can be very severe that require hospitalization. The fatality of this type of pneumonia reaching about 30 to 50%, especially in immune-compromised patients or those patients having chemotherapy. The diagnosis is by demonstration of Legionella antigen in the urine of the patient or by fluorescent antibody on the sputum. Sputum culture is the gold standard of diagnosis.